Good morning to you all. And if you woke up this morning feeling still in the United Kingdom, I bet you're right. So it's my pleasure this morning to introduce Richard Hayes from the London School of Hygiene and Tropical Medicine. So the plenary today is about the paradigm shift focus on the HIV prevention continuum. Richard?
Good morning, and thank you very much for the invitation to speak at this meeting and for the introduction. It's a great pleasure to be here. So I'm Richard Hayes. I'm from the United Kingdom still, and I've been working on HIV prevention mainly in Africa for the last, well, more than 25 years now. What I plan to do in this brief talk this morning is to talk about the prevention continuum. And here's a brief outline of what I hope to cover. So I'd like to begin just very briefly reminding us of what the question is, the problem is, which is how to achieve steep reductions in incidence in the most cost-effective way, and particularly in resource-poor settings where there are generalized epidemics. I'd like to say something about combination prevention, what we know about what methods work, and how they can best be combined, and what questions need to be answered in this field. And then I want to focus in on treatment as prevention as a component of combination prevention. And again, to ask what questions need to be asked about delivery of TASP and its cost effectiveness. And this includes a discussion of universal test and treat as a particular approach to treatment as prevention. And finally, I'd like during this talk to look at how we can enhance the evidence base to ensure that policy really is based on evidence in future and not on beliefs, strongly held beliefs, and subjective opinion. I think this is very important. So I don't think I need to spend very long on the problem because I know you're all very familiar with it, but just to remind ourselves that there have been reductions in HIV incidence in many countries. This is good news. But HIV incidence remains very high in many parts of sub-Saharan Africa in particular, and especially in southern Africa. We know that the number of new HIV infections continues to greatly exceed the number of HIV-related deaths. And of course, that's partly because the rate of deaths has been significantly decreased, thank goodness, to ART. This, however, means, of course, that because the number of new infections exceeds the number of deaths, that prevalence continues to increase year by year. And that means that unless we can find ways of steeply reducing HIV incidence, it will become increasingly difficult to sustain HIV treatment services for all who need them in the long term. So just a couple of diagrams just to remind us of those key points. So on the left, you can see the incidence of new infections decreasing over time. You can also see on the right the number of deaths also decreasing, but the number of new infections exceeds the number of deaths, and therefore the prevalence at the bottom continues to increase. So we have to find a way of turning this incidence line down very steeply so that not just incidence but prevalence can be decreased. And of course, the other thing to remind ourselves of is that we still have a very severe epidemic in many parts of Africa. These are the national data for South Africa, showing prevalence by age and sex, and as you can see, still showing extremely high prevalence rates in many of those age-sex groups. These are national data, so in particular areas, the situation is much more severe than that. So let's focus now on what can be done about this, and I'd like to turn to combination prevention. I think it's now widely accepted in the HIV control field that we will need a combination of several partially protective strategies if we're to actually achieve those steep reductions in HIV incidence that are called for in these countries. These strategies may include structural, behavioral, and biomedical components. We have to look at a range of strategies. And those combinations will need to be tailored to the local context and the transmission patterns in each area and each country. And ideally, this should be based on this concept of know your epidemic, knowing where the transmissions are taking place. This is just a UNAIDS, a nice little diagram here reminding us of the many factors that contribute to the transmission of HIV, biomedical, political, structural, behavioral, etc. And in any of these domains, we may be able to intervene to reduce HIV transmission. And then in terms of knowing your epidemic, to guide the design of combination prevention programs, you'll all know that there's been a lot of work done across countries in Africa, but elsewhere in the world as well, to try and understand where new infections are taking place. How many of them are due to transmission within regular partnerships? How many are due to or associated with sex work or particular groups at high risk, and so on. So designing those most effective combination prevention programs ideally is based on a good knowledge of what those patterns are in any particular area. There are many preventive measures that could be incorporated in such combination prevention programs. This is Mike Cohen's slide, which I really like, which just summarizes the evidence we have from randomized trials of effective interventions. So these range from, at the top, the HPTN 052 trial, which you're all familiar with, showing a 96% reduction in HIV due to early ART, and then through various PrEP trials, the male circumcision trials, that's actually three trials in Africa, more PrEP trials and microbicide trials, the STD trial in Tanzania, and the HIV vaccine trial in Thailand. I should just note for completeness that this slide only shows the positive results from trials, and there are obviously other trials of PrEP, of STD treatment, of vaccines, and of other interventions that have not shown protective effects. But we have a range of strategies here that could be considered for inclusion in these programs. The other thing you won't see here, I don't know if you've noticed, is there's nothing about behavior change. And that's because we actually have, although we believe that changes in behavior have made an important contribution in many places to reductions in HIV incidence, we actually have very little rigorous trial data on what specific behavioral interventions actually lead to such changes in behavior. But I think it's evident that most combination prevention programs would include behavioral components. There are many programs and studies in progress looking at various different combinations. I think it would be very difficult to carry out trials of all these different combinations, so we're going to have to learn in the best way we can from programs and studies as we go along. There have been modeling... there we are. There have been modeling studies to look at different strategies. A lot of studies have been published on this, and I won't review those in detail. This is just one example in one of the UNAIDS background papers, and it just illustrates a couple of nice points, I think. So on the left-hand side is a concentrated epidemic. This is Karachi in Pakistan. On the right-hand side is a very generalized epidemic in KwaZulu-Natal in South Africa. And the green and blue lines show the modeled effects on HIV incidence of two different strategies to combination prevention. The green one is called a broad and shallow strategy. It has lots of components, but not particularly intensive. The blue line is a deep and narrow strategy, which actually includes early ART and the intensive promotion of that. And you can see both that the effects are different in these different epidemics, as one perhaps might expect, and also the relative effects of these different approaches are different in Pakistan and in South Africa. So what are the questions we need to be asking about combination prevention as we go forward with these different programs? So I think they're fairly obvious questions. We need to know the effectiveness of these different combination prevention packages tailored to different populations, and what are their effects in different populations. We need to look at how best to combine interventions to get the best effect, so to capture synergies and to avoid as far as possible redundancy. So that is to add together interventions which provide more benefit, if you like, than their individual contributions, and to avoid situations where once you've intervened with intervention A, intervention B gives you little additional benefit, so to avoid redundancy. But there are also many implementation science questions here, I think. So questions about the implementation of these programs, the most important being to determine how to achieve high coverage. And I'll be coming back to this later in the talk, in order to achieve the intended benefits and to do so at minimum cost and with maximum sustainability. And that's going to be quite a challenge, I think, particularly in these resource-poor settings. So in the second part of this talk, within the context of combination prevention, I want to focus on treatment as prevention, including universal test and treat. And I'd like to start by pointing out that TASP is intimately linked with combination prevention, and that's for two reasons. Firstly, treatment as prevention is likely to be a key component of many combination prevention programs, perhaps all combination prevention programs, and one indeed with stronger evidence of benefit, as we saw from Mike Cohen's slide, than most other components. Secondly, and I think we should always remember this, treatment as prevention is itself, even if you forget about all the other components, it is itself a combination prevention intervention. And I've shown here a slide that my colleague Woffer presented, I think, at last year's meeting, at the bottom of the slide here, just showing the key components of a universal test and treat approach to treatment as prevention. So starting with test uptake, followed by linkage to care, onset of ART, and then achieving retention on ART and viral suppression. So universal test and treat is a combination prevention strategy in itself. And this brings us, of course, to this concept which I know was discussed in detail yesterday of the cascade of care. Just to remind you again what those main steps are. It starts with HIV testing and regular retesting, regular intervals if HIV negative, with the aim that everyone in the population should know their HIV status. It's followed by this very crucial link, the component of linkage of those individuals to services. And for both negatives and positives, I think that would potentially mean other prevention services, behavioral interventions, condom promotion, STD treatment, perhaps PrEP, male circumcision, and so on. And for HIV positives, it means linkage, rapid, effective linkage to services for treatment and care. And I think we know that that has been a very challenging step to achieve high coverage. And then the third step is the steps leading up to the start of ART, so monitoring, follow-up, starting on ART, and prompt onset of ART when eligible. And of course, this is a step which can be simplified in a universal test and treat approach where a CD4 threshold is not required for onset. So that's a step where we can actually do something to make things quite a lot better. And then fourthly, finally, last but not least, is the key importance of retention, monitoring for retention, for toxicity, giving adherence support, and the aim here, of course, is to achieve long-term viral suppression. Now, these are not real numbers, these are just illustrative numbers, just to remind us of this key point, which it took me a while to really understand this. But I first saw this actually about 20 years ago. This was called the PO model, and it was actually developed for TB control, this idea of a pyramid or a cascade of care. And then we applied it to STD treatment, and now it's very well known in this field of HIV. And the point is simple, which is that even if at each step you can achieve really very high and impressive coverage rates, you then have to multiply these together, and you very quickly get to very low figures, as you can see in the illustration here. So the key task for us as we implement these programs is to try and get these 4 different numbers as high as we can. So UNAIDS, of course, have given us some targets for this. The 90-90-90 target, so 90% of all people should know their status. 90% of all those diagnosed with HIV should receive sustained antiretroviral therapy. It doesn't actually say how quickly they should receive that. And then 90% of all those receiving ART should have durable viral suppression. And of course, they've done their multiplication, and that's a bit better than 40%. So 0.9 cubed is 0.73, so that would give 73% would be virally suppressed. And that's a threefold increase over current estimates. And UNAIDS have described these as ambitious but achievable new targets. So I'd certainly agree with the first part of that statement. They're clearly ambitious. I think most of us would agree that they are probably useful targets. They are very helpful for advocacy, and they are, aspirational targets that we can all aim for. But I have to say, I've discussed these targets with quite a few people who are carrying out programs in the field in resource-poor settings, and even those who are firmly committed to this approach of treatment as prevention do think that these targets will be very difficult to achieve in practice. But we'll have to see how close we can get to these and work very hard to do that. Just to remind us what a mountain we have to climb, I think you've probably all seen this slide from the US against one of Mike Cohen's slides. So showing that even in this resource-rich setting, where earlier ART has been the norm for a longer time than in other parts of the world, this cascade is very problematic. And in fact, here it results in about 28% successfully virally suppressed. These are some data put together by one of my colleagues based on a set of published papers, really based on experience in Africa over the last decade or so, and summarizing the results that we have at each step of the cascade. There's a range of values in each case. I think there have been some improvements in these figures during this decade, so the situation is probably somewhat better than this now. But I'm showing this just to remind ourselves how difficult this is going to be to get these figures up to those 90% targets. But that is what we have to try to do. I just wanted to look very briefly at the first step of the cascade for universal test and treat, which I think is a very, very critical one, which is getting high rates of testing. This, I think, is going to require intensive community-based campaigns. There are different approaches that can be used for that, as we've seen. One of them, which I think is a very attractive approach, is home-based testing, and this was a meta-analysis carried out by my colleague Kalpana Sabapati and colleagues, looking at the published evidence on this, and you can see that from the forest plot, widely differing coverage rates, but the overall figure was about 83% over those studies. So that's actually quite promising. I should say that these would generally have been rather well funded, well resourced and well supported, often research program studies. So whether we can achieve similar results on very wide-scale routine rollout, that again is going to be something we have to work very hard on. It's going to be quite a challenge. But cautiously optimistic results there. I should mention one thing, which is that I think based on a lot of practical field experience, there are some barriers to achieving these very high coverage rates, particularly in men, and this is what I'm being told by many of my colleagues working in different programs. It's difficult to contact the male population often and to get those high coverage rates that we need. So that is a particular area where I think more work will be needed. So in the last few slides, I just want to look very briefly at why we believe more research is needed on treatment as prevention at the same time as we go forward with interventions. And I think there are a range of very important questions that need to be addressed if we are to get as close as we can to those very ambitious targets. Just going through the questions quickly. So how can treatment as prevention be delivered most effectively? in practice? What coverage can realistically be achieved on the ground at each step of the cascade, and what are the barriers to that, and what are the solutions to that we can share together? How can other prevention modalities be incorporated in these programs, such as male circumcision, PrEP, and so on? That's quite an interesting question. Most of the existing TASP programs do include other such components. And then, I think very importantly, what are the adverse effects of TASP programs? So these include the potential for poor adherence and the development of drug resistance, drug toxicities. Many people are fearful about sexual risk disinhibition, as seems to have occurred in some Western countries, as ART has become more widely available. Stigma, I think, could go either way. You could easily argue that universal approaches could reduce stigma, but equally there could be an increase. And of course, there are many concerns about overburdening health services, which in these resource-poor settings are already very stretched. So what are the adverse effects of TASP programs? And then, I think very importantly, what is the impact of achievable, sustainable TASP programs that can be delivered in the field on HIV incidence and on morbidity and mortality? And what is the balance of the costs and harms against the benefits? And I believe that research can and should be done at the same time as efforts to expand testing and treatment are intensified. This will include implementation science. We need to learn from these programs as we go along, as they're implemented. It's often only when you try to implement a program that you find out what the major barriers are, and then can try to find the solutions to those problems that can then be shared with the wider community. So there's a role for demonstration projects. There's a number of these already in progress. And I think one area where we could probably do much better is in routine program monitoring. So improving the usefulness of the data we get from routine programs, if you like, to find out how well these programs are performing and to identify bottlenecks and problems. And then, as you know, there are a number of randomized trials, in addition to these implementation science programs, that are collecting rigorous data on the impact of these interventions on HIV incidence at population level. These studies will give us a direct comparison of benefits and harms and provide, I think, rigorous evidence-based data on cost effectiveness, which I hope can inform health policy going forward. Many modeling studies have been done. You can base policy on models, and that, models may have a role to play in this field. But I'd just like to again remind us that different mathematical models have come up with very different projections about the impact of these interventions. This slide shows a comparative exercise was done where a number of models were used with the same assumptions, critically, the same input assumptions in terms of coverage and so on. And they show a wide range of projections, particularly in the longer term. This is the effects on HIV incidence. And then in the next slide, this is person years of ART per HIV infection averted. And this actually is a key indicator of cost effectiveness, in fact. And you can see here that the models vary very widely in their projections. So I don't think we can just rely on models. We need empirical studies, both to find out what coverage can be achieved in practice and to measure the actual impact you can get on HIV incidence, given the many uncertainties in the transmission parameters that, on which that is based. So then finally, just to mention, there are 4 major trials in progress. There isn't time to go into the details of these. There's the POP-ART trial, of which I am the PI, which is being carried out in 21 communities in Zambia and South Africa, looking at universal test and treat. There's the SEARCH trial in Kenya and Uganda, being carried out in 32 villages there, based on community health campaigns at annual intervals, again offering immediate treatment to those who are positive in the intervention arm. There's the Botswana combination prevention trial, where the guideline for onset of ART is either fulfilling current national guidelines or a viral load above a defined level. So this is not universal immediate treatment, but it will, I think, cover a very large proportion of the population. And finally, the ANRS TASP trial in KwaZulu-Natal at the Africa Centre in South Africa, where they've been introducing this in a phased manner. I think the total number of communities is 24, and they are, again, doing annual home-based testing, and in the intervention arm, they're providing immediate treatment, and the control arm will get the national guidelines. So in summary, combination prevention has the potential to steeply reduce HIV incidence, even in the worst affected countries in sub-Saharan Africa. Treatment as prevention is a key component of combination prevention. And I think that as efforts to promote treatment as prevention are expanded, we need implementation research to tell us what approaches actually work best to achieve high coverage and impact. The trials of TASP, I wish I had more time to go into the details of those, are quite interesting because they're actually complementary, and they together will answer a wide range of questions in this field and will provide rigorous data on uptake, costs, adverse effects, effectiveness, and cost effectiveness. And I hope that this evidence will help to inform the future planning of treatment as prevention implementation in many parts of the world, and will inform resource allocation. So I'd just like to thank my colleagues Sarah Fidler, Kalpana Sabapati, and Helen Ailes for slides and assistance with the preparation of this talk. Thank you very much. Okay. Are there any? Yeah.
Yep. Are there any questions? We have time for one or up to two questions. Yes.
Two, you didn't talk about time to data release, and I think it's really important in this audience that everybody knows the length of time it's going to take to get impact data from those trials, and how it may be, I don't want to put words in your mouth, 2017 or 2018. So we have to have some bridge in between where we can get some idea how to plan, realizing that the definitive trials will be available.
Yeah, that's a very good point. I wish I had more time to go into the details of the studies. Certainly I can speak for the pop-art trial. We will not have the final impact data before 2018, so we have some time to wait for this. I think the Search and Botswana trials are probably rather similar time scales. The South African one may be a little bit earlier, so we need to wait to see the timeline for that. Clearly, efforts to expand treatment as prevention cannot wait for those results to be available, but I think they will still be extremely valuable results.
Sorry, I want to put in a plug. Thank you for a great talk. I wanted to put in a plug. UNAIDS and AVAC actually has put together, I think, a nice report on all of the treatment as prevention trials, and it gives timelines and also expenditures. And so that report is actually on the AVAC site. I know you didn't have time to go into it, but if anybody's interested, go there, look, and the trials are all featured and described. And it was built by the researchers that are doing the trials, so it's a quite nice report.
Yeah, thanks for reminding me of that. Should we just take one more?
Hi, I'm Mariam Shamanish from UCL. It might be a stupid question, but if the rollouts, if policy changes at the rate it's changing, then will the trials not potentially be contaminated if the same countries end up having treatment as prevention anyway in both arms, or is that not going to happen?
Well, we don't know exactly what's going to happen. We've seen how the guidelines have changed repeatedly over the last few years. I can speak for pop-art. Both Zambia and South Africa are adopting the new WHO guidelines, so they will be starting treatment from a CD4 count of 500 in future. That's being gradually implemented now. The trial teams have been looking very carefully at what effects that will have on the implementation and power of the studies. I can speak again for pop art. We have a very strong modelling team, actually, so I hope you won't take any of my comments about modelling as being negative. I think modelling plays a very important role, and they've helped us in the design, and they will be helping us in the analysis of the study. And we can say that based on our projections, the pop art trial should still be highly powered for most of its main outcomes. Thank you.
Thank you very much, Richard.